Welcome to the lecture for Counseling Perspectives on Psychopathology. I'll be talking about the classification and diagnosis of psychopathology. So starting off, just defining some terms, different things we might talk about. Assessment. So assessment is a process of gathering, analyzing, and synthesizing information to answer some question, right? And that may involve diagnosis or it may not, depending on the purpose of the assessment, right? And then diagnosis is the process of applying a set of decision-making rules to determine what diagnostic label best describes a person's experiences. So after you do an assessment, you gather information, and you may use the information gathered to help you decide how to apply a set of diagnostic rules to reach some diagnostic decision. Right. And also your assessment might include finding out what diagnoses a person previously was labeled with. But then both of those differ from classification, right? Classification is the process of ordering objects or experiences into groups, usually. And when we talk about classification, we talk about establishing usually a taxonomy, right? And taxonomy means a couple things. One, it's the science of classifying things. Probably let me stop for a second. So it's a science of classifying things, and it's also, you can talk about taxonomy, the science. You also talk about via this process of taxonomy, you establish a taxonomy. And when you talk about a taxonomy, you're talking about a set of rules for classifying things. So for us, our set of diagnostic rules are a taxonomy. Probably one taxonomy that most of us learned in school at some point in time was the taxonomy of Linnaean taxonomy for biology, right? Where we talked about there's 3 different kingdoms, and the kingdoms can be subdivided into classes, and they in turn can be subdivided into orders and families and genera and species and so on and so forth, right? So that's a taxonomy, and so is what we use for psychopathology. And a term you may come across when talking about taxonomies of mental disorders, taxonomies of psychopathology, is the word nosology. And nosology is simply taxonomy in the medical world. And so it's kind of one of the, it might be a cue to you sometimes, or a clue. If somebody's talking about the taxonomy of psychopathology, they're probably coming from a more psychological perspective. And if they're using the word nosology, which comes from the medical world, it's probably more of a psychiatric perspective. And there is a lot of overlap between the psychological perspective and the psychiatric perspective, but there's also some significant areas that don't overlap and where they diverge, which we'll see throughout the course of the semester. Okay, so we're talking about classification and also a little bit about diagnosis, not so much about assessment today. So in the first place, why do we classify and also why? So a lot of stuff applies to why do we diagnose. Primarily, it's for communication purposes, right? Having a classification, being able to divvy things up and apply labels to them, gives us a common language to talk about psychopathology. If you just look back through some of the older writings in psychopathology, some of the historical stuff, it'll be really clear why a consistent system for classifying and labeling psychopathology is important. If you read about melancholia from one author, he or she might be describing a very different phenomena than some other author who also describes melancholia, right? They may use the same name but mean 2 totally different things because there wasn't a systematic way of classifying, and there weren't systematic rules being applied. By the same token, you might have 2 different authors working with exactly the same type of patients, maybe even the same patient, who has obviously the same experiences, but then using different terms to describe these same experiences. And when that happens, it creates a lot of difficulty communicating in a variety of settings. And the settings we're usually concerned about include among providers of care, right? So if if I know we're talking about the same thing when we use, the words major depressive disorder or dysthymic disorder, if I can just say that phrase, that's a lot easier than having to say, I've got this client who has depressed mood most of the day, or most of the day for most days, more days than not, experiences difficulty concentrating, has a decreased appetite, has some sleep problems, feels guilty all the time, and also is suicidal. Right? It's a lot easier to say this client suffers from major depressive disorder. Right? So I can communicate a lot of information in a short amount of time. So it helps with when professionals want to consult with each other. They can communicate really with fewer words and with greater efficiency. It's also really important for researchers, right, to be able to have a shared language. It allows for the synthesis of research findings. Work done on similar patients can be more easily compared and combined if researchers are using the same rules to classify their subjects into groups. Right. So if you find that this treatment works with this group of people, and somebody else finds that treatment didn't work with some other group of people, it's really helpful for us to know, okay, these two groups, did they have the same diagnostic label? Did they have the same experiences, or were they different? Right? If they had different labels, different experiences, then okay, so this treatment might work for this type of thing, but not this. If we don't have any kind of common language, then we don't know how to compare one study to the next, and research can't contribute to the furtherance of our knowledge. Right. Also, it's important for communication between clients and providers. So sometimes, not always, but sometimes it's beneficial for clients to have a label, to whatever experiences they're having that are for mental disorders, usually things that are difficult in their lives. It can be comforting and reassuring to be able to call it something rather than just, I don't know what's going on, I feel like I'm going nuts. But to be able to have this label, oh, it's this, okay, it's this post-traumatic stress disorder, and other people have it. I'm not the only one that feels this way, and there's all this research about how to treat it and what it's like. That can be reassuring for some people. Again, depending on the diagnostic label, some labels can be more reassuring than others. Sometimes a label, if the prognosis is poor, it's not so helpful to maybe have that label. But for the most part, having something to be able to describe your experience, takes away some of the anxiety about the experience itself. And especially in today's day and age of technology and the availability of vast quantities of information, if a client wants to know more about what's going on with them, if they have some label, okay, I've been diagnosed with obsessive compulsive disorder. Now I can Google obsessive compulsive disorder instead of having to Google, do you sometimes wash your hands 20 times a day? Because that might pull up all kinds of stuff. Now I can Google this one kind of clear phrase and pull up lots and lots of information. So it also helps clients get information not only from their providers, but from other sources of information as well. So the kind of utilitarian benefit is primarily for communication purposes, at least from especially a clinician's point of view. But it also serves as a descriptive basis for the science of psychopathology in a couple of ways. One, it helps identify the targets of study, right? There are infinite questions that could be asked about human experiences that fall outside of the norm, things that we might consider psychopathology. A classification system helps provide at least some focus for the research, right? So, okay, I'm going to do research on all these people who meet criteria for this disorder, or all people who meet criteria for this disorder, rather than saying, okay, well, I'm going to do research looking at people who are sometimes sad, but not irritable, but they don't have hallucinations. But right, instead of having to kind of have all these different rules for what your sample is, you can use these diagnostic categories because they already have rules themselves to say, okay, they have this and they don't have this other thing, right? So it helps identify the targets of study, and it also contributes to theoretical development. Right? Science doesn't advance simply with the accumulation of evidence. So people just finding stuff out, that doesn't make science move forward. Right? There must be some organizing principles to make sense of all the accumulated evidence, and this is where theories come in. Right? But you can't have theories that are helpful without precise language for defining the concepts within a theory. And that's what classification systems provide. They provide some of the concepts for theories, right? So if you want to come up with a theory about depression, it's helpful to define what depression is. And the classification system helps do that. It doesn't do it completely, but it helps with that definition. And you can at least say, okay, in this study, in this theory, it's consistent with this understanding of depression, or maybe you want to say it's not, but it gives you some basis that everybody can relate to and understand. And then last, not to be underestimated, are the sociopolitical functions. Right, because the systems, classification systems, are used for more than helping people and conducting research. Right? There are economic considerations, right? The classification systems play a role in determining what mental health services are worth paying for, right? Oftentimes, if as a clinician, you'll get reimbursed for treating people with DSM-4 diagnosis, and you might not get reimbursed, or maybe not or you might be reimbursed at a lower rate if they don't meet criteria for this clinical diagnosis, right? So they're very kind of real-world economic pay the bills implications here. And then another one, which is kind of a point of controversy we'll come back to later, is some have argued that we classify and diagnose to maintain power of those who have power. So it's argued by some that it's a way of exerting power over people who don't conform to society's agreed upon rules. Right? So in the name of this kind of paternal beneficence, we deprive people of their liberty, right? Not as much as we used to in terms of locking them away in asylums, but still there are state hospitals that people can be committed to against their will, and anytime you apply a diagnostic label to someone, it changes to some degree their freedom, right? There are certain jobs that they are no longer going to be considered for if they have had this label applied to them in their medical record. So these labels do have power, and that power certainly has been misused in the past and could potentially be misused currently. Okay. So, how did we get to where we are now, to our current system? So, it's a very kind of brief review. Early on, the early theories were early systems were based on early theories of etiology, right? Like the humoral theory, right, with the black and yellow bile, blood, and phlegm, right? So, your problem. So, I'm going to classify all disorders caused by too much blood over here, and these are disorders caused by too much phlegm, right? So, dividing pathology up based on the presumed cause, which was problematic to the extent that the etiological explanations, the causal explanations, were incorrect. So that's kind of where we started. And then a big leap forward came with Kraepelin, maybe or maybe not intentionally, but he had a popular psychiatric textbook, right, that described different types of psychopathology. And each chapter was about a particular experience. Right? People that have this experience versus people have this experience. And kind of de facto, his table of contents became a classification system. And so the title of the chapter became basically a diagnostic label. More than he intended for that to happen. Historically debatable. But that kind of got the ball rolling in towards the kind of the current system, a more modern system. And then we have some other things going on. You have the Manual of International Statistical Classification of Diseases, Injuries, and Causes of Death, right? The ICD, which initially was an international system for classifying medical diseases that killed you. And then when the sixth edition of it came out, so there were several revisions, obviously, after World War II, they revised it to include things that didn't cause death, and they included mental disorders or mental diseases. And largely in response to that, the APA, the American Psychiatric Association, not the American Psychological Association, but psychiatric, in America, came out with the first DSM, the DSM-1, Diagnostic and Statistical Manual of Mental Disorders, right? Because, the ICD came out with theirs, but then throughout America, there were several different classifications being used, and usually they were institution-specific. So, if you work at St. Elizabeth, you use this. If you worked at SUNY, you use this. And politically, they felt it was necessary to come up with some sort of unified American version, and that's what the DSM initially was. And as you probably know now, very popular in America, but also used and adopted by many other countries as well. So the DSM, first one came out, and both 1 and 2 reflected kind of a combination of psychodynamic theory, right, Freudian stuff, and then also Kraepelin's taxonomy, his table of contents, which really had a strong biological emphasis. So it was a lot of kind of psychodynamic biological stuff, and they divided stuff up between organic brain dysfunction and non-organic brain dysfunction. And beyond that distinction, the other major distinction was between psychosis and neurosis. Right? So these are psychotic disorders and these are neurotic disorders, and that's how they kind of divided things up. Move forward in time, we get to the DSM-3 and the 3R, which really represented, 3 represented a significant shift away from just descriptions of categories, because that's what 1 and 2 were. It's like, okay, here's neurasthenia, and here's what it's like. And so no kind of diagnostic criteria, like you have to have this and you get diagnosed. It's just, here's the disorder, here's a description of what it typically looks like. With 3, they moved to kind of diagnostic criteria, a list of symptoms with this this prototype model. Right, and in a prototype model, for each disorder, there's a list of symptoms that are typical, right, prototypical of the disorder, but no single symptom is required for diagnosis, nor is any single symptom sufficient for diagnosis. Right? Rather, some combination of the prototypical symptoms is required to be put in that category or diagnosed with that label. Right? And that's the big shift in 3. And then 3R was just a revision based on research that was generated by the 3rd edition. Okay. So it's important here to kind of pause for a moment and think about, well, why the shift? Because it's a very big shift. Well, because the use of 1 and 2, those versions, led to incredibly low reliability. People would diagnose the same client with different disorders, right? And the prototype model increases reliability. Unfortunately, it does it at a cost. It increases reliability by decreasing the specificity of a category, right? So if someone comes in and is depressed, and practitioner A notices that she's sad, doesn't eat much, and feels guilty, he'll diagnose her with depression. Now, practitioner B notices that she's sad, feels tired all the time, and can't concentrate. She'll also diagnose her with depression, right? Because you can do that. They don't have the same symptoms, but they share some symptoms, and all of them are symptoms of depression. Now we've increased agreement, right? We've increased reliability. But these 2 people have different experiences. Do they really have the same disorder? And that's debatable. But now when I say someone has depression, it's not as clear what I mean. There are a couple of different combinations of symptoms that they could be presenting with when I give you that label. It's less specific. But it did improve reliability, and that's probably a good thing. They move on to, that's why I move on to the 4th edition and then the recent text revision. And the text revision, nothing major, just cleaning up some of the wording, making it easier to read, and then correcting a few errors in the supporting data, not in the diagnostic criteria themselves. But 4, based on research generated by the previous editions, and motivated by to some extent by those new findings, but also because they wanted a version that moves moved still further away from an assumed etiology, right? Which 3 had already tried to do that. And it's debatable how successful they were. It's certainly not as psychodynamic as the older versions, but there still seems to be some implication of biological etiology, even though in 4 it says very clearly psychological or biological or behavioral or social, causes. It still seems tilted toward a biological model. But other than that, one kind of significant addition to the 4th edition carried over into TR was the inclusion of a clinical significance criteria for almost every disorder. So to be diagnosed with any disorder, you have to have these symptoms, and it causes clinically significant impairment or distress in academic, social, or occupational functioning. Right? Which means that 2 people could have identical symptoms. They go see 2 different clinicians. Both clinicians recognize they have all those symptoms, but one diagnoses them with a disorder, the other doesn't, because he says, well, they have those symptoms, but that's what I kind of expect to see given what's going on in their life. It's not clinically significant. It's not important enough to merit a diagnosis to call for treatment. So there's a lot of wiggle room in there and a lot of power given to clinicians, to anybody with a license, medical license or license to practice mental health. You become the gatekeeper and you determine that line between normality and abnormality. It's not simply the symptoms there and it's abnormal. No, the symptoms are there, and using your professional judgment, is it clinically significant or not? Okay. And just like in Spider-Man, with great power comes great responsibility. Okay, before I move on, just kind of want to note, one of the authors of the chapter you read was involved in the crafting of some of the versions of the DSM, and his allusions to political forces and compromises along the way are very telling. I think there are many other books and articles out there that you can read that talk about some of the personal and political agendas that shape this supposedly scientific process. So there's a lot of stuff that went on behind closed doors in shaping this book, which is one more reason to not accept it blindly as gospel. So be somewhat skeptical. It's not to be rejected, but there should be some skepticism there. Because it's not just based on science and clinical experience. Okay, so how we got there now. What is the current system? Well, it's out of order. There we go. Categorical nosology. All right, so we divide psychopathology up. We draw boxes around the different aspects of human experience and create these categories. And each category is a mental disorder. Right. It's important to kind of pause here for a second and talk about how the DSM defines a mental disorder. Okay, so a mental disorder is a clinically significant, or is it clinical significant? A clinically significant behavioral or psychological syndrome or pattern. Okay, so it's behavioral or psychological. It's not strictly medical. They're saying it's something that's going on behaviorally or psychologically, and they put in psychologically because it could be thoughts and emotions, which some people say are just examples of behaviors. Other people argue about that, so they put in both those terms. And it's a syndrome or pattern. So it's not just one thing you do. You don't just have one thought, but it's some sort of collection of experiences that, and if it's a pattern, it's not random, right? So it's not just unique to you. It's not idiographic. It's other people have it too. So it's this kind of pattern that repeats across individuals. Behavioral psychological syndrome or pattern that occurs in an individual, which that's oddly really significant too. So the psychopathology happens in you. So if you're in an abusive relationship, the DSM, the way it's written now, can't diagnose the relationship, right? The pathology lies in you. And there are some V codes in there to identify that you may have problems in your relationship, but we're not diagnosing the dyad, or if there's kind of if you're an MFT person, you think about this family system that's toxic, we can't really diagnose that. the pathology is placed in the individual, not in any other part of the system. Okay, so clinically significant behavioral or psychological syndrome or pattern that occurs in an individual, and that is associated with present distress, disability, or with a significantly increased risk of suffering, pain, death, pain, disability, or an important loss of freedom. Okay, so it's this clinically significant pattern in the individual. It's causing distress, so some sort of you're not happy about it. It's causing some sort of psychological pain, or disability, which is the kind of dysfunction we talk about. It's getting in the way of doing stuff you should be able to do, with the assumption being that you should be able to go to work and go to school, and that's the correct way of being, or an increased risk of suffering, death, pain, or disability. So if somebody runs out into traffic, that's a behavior associated with increased risk of death, pain, disability, or suffering, right? So doing things that put yourself in danger, that's put in there too. So it's all that. And then there's a couple of caveats. One, it must not be merely an expectable and culturally sanctioned response to a particular event. And the example that you talk about here is loss of a loved one. So whenever you experience depressive symptoms following a loss, if it's culturally appropriate for you to express those symptoms, to cry, then it's not a diagnosis. If you express those same behaviors and it's not culturally appropriate, then it might be a diagnosis. So this is kind of culturally bound. You need some cultural awareness and competence to be able to diagnose appropriately, because you have to, you should take into consideration the person's culture of origin. What happens more frequently is the clinician makes a decision based on their own culture and say, okay, for my culture, it's not appropriate for you to be crying anymore. You know, it's been 3 months. You're supposed to be over it. Therefore, I'm going to diagnose you with depression. Right? So they base it on their own, when it should be based on the client's culture, which takes work to figure out what that is. Right? So it must not be merely an expectable and culturally sanctioned response to a particular event. And the other caveat is that deviant behavior and conflicts with society, so doing stuff that's kind of weird or protesting, are not mental disorders. Unless, a caveat to the caveat, unless the deviance or conflict is a symptom of a dysfunction in the individual. Okay, so if you're out on a ship chasing down whaling vessels and putting yourself in danger, right? So that's risk of suffering, death, pain, or disability. That's not a disorder. You're not, you don't have a mental disorder if you're doing that, unless you're doing that because you have dysfunction. With the idea being this kind of circular logic, well, if you have a delusional disorder and you think that whaling ship is about to kill the whale who is your mother, and that's why you're doing it, then yes, that contributes to your diagnosis. But if you don't have that delusion, then no, it's not a mental disorder. And this is put in here. This kind of deviant behavior and conflict society are not disorders, because historically people used psychiatric diagnoses to contain individuals who conflicted with society. Political dissidents often held in, if you don't support the Fuhrer, you must be crazy. We need to help you. We're not going to put you in prison because maybe you're a very rich person, but we will send you to an asylum where you can be looked after and cared for and make sure you don't get into any trouble. Right? So they put that in there to try to keep that from happening anymore. Okay. So one more time, kind of the whole thing through. A mental disorder is a clinically significant behavioral or psychological syndrome or pattern that occurs in an individual and that is associated with present distress or disability, or with a significantly increased risk of suffering, death, pain, disability, or an important loss of freedom. It must not be merely an expectable and culturally sanctioned response to a particular event. And deviant behavior and conflicts with society are not mental disorders unless the deviance or conflict is a symptom of a dysfunction in the individual. Okay. So there are a couple of assumptions implicit in that definition, which we have up here. One, it assumes that we understand how people should function, right? So that this syndrome is an indicator of psychological, biological dysfunction, that something's not working the way it should. For us to diagnose that, we must know how people should function. Okay, so we must know how happy you should be, how sad you should be, how imaginative, creative, magical your thinking should be. That there's some line that says, okay, if you can imagine, maybe the person who wrote Star Wars, if you can imagine this fantasy world with evil and good forces battling, that's normal. But if you can imagine it and then start to believe a little too much, you're going into, that's beyond the function of creativity, the normal function of creativity, and then it's now pathological, right? You may be delusional, right? And I don't know that we do know how people should function, especially when it comes to levels of emotionality, because there are certainly cultural differences in emotional expression and, to some degree, emotional experience. So if there are different rules depending on where you were raised on how happy or sad you should let yourself be, it seems kind of dangerous to say that, okay, to draw a clear line in the sand, that if you're this happy or this sad, now that's pathological. The other assumption in there is that some pattern of experiences, this syndrome, is a sign of something else. So it's not just a pattern in and of itself, right? That's what it says it is, that the mental disorder is a pattern. But what happens is we reify the pattern. We make it real. So this pattern is reflective of a concept, which is an abstract thing. But we treat it as if it were a concrete thing, right? Because if major depressive disorder is a pattern of symptoms, then that's what it should be. A pattern is a concept. But we treat it as if it is a thing. You're being treated for depression. Oh, I got depressed. I was cured of my depression. So we're treating it as if it is something, usually as a disease. But in the definition, it really is an abstract concept. But the tendency is to reify it, to make it real, because it's easier to talk about and easier to understand at that level. But there are some dangers to that, which we'll talk about throughout the semester. Some other things about the current system. Largely using polythetic instead of monothetic criteria. And polythetic criteria sets means that some set proportion of diagnostic signs or symptoms must be present to make a classification decision, as opposed to monothetic, where all the criteria must be present. Right? And this is what we talked about before with that prototype model. It increases the reliability of diagnostic decisions, but also contributes to that slackening of specificity and increases the heterogeneity of the categories, right? So two people with the same diagnosis can present with different symptoms, or you can have different symptoms and still get diagnosed with the same thing. For borderline personality disorder, there are 100 different possible combinations of symptoms. For obsessive compulsive disorder, two people both diagnosed with OCD could have 0 symptoms in common, share 0 symptoms. Think about that. But they have the same disorder, but none of the same symptoms. That's maybe concerning. Think about it. Okay, and then the last thing, kind of just about the system, the diagnostic classification system, is that it uses multi-axial diagnosis, and that means that disorders are classified into categories. But when you begin the process of diagnosis, you do more than figure out which categories or diagnoses best describe a person's clinical presentation. You actually make multiple decisions and notations about the person's experience on several of these axes, which we'll talk about. So for Axis 1, that's where you make decisions about clinical disorders and then other conditions that are of focus of clinical attention. So it's pretty much all the disorders in the DSM, all the clinical disorders, other than personality disorders and mental retardation. And the reason there's an Axis 1, Axis 2 split, and that they're put in different disorders, is originally Axis 1 disorders were thought to be those that were state disorders. So state as opposed to trait, so kind of temporary. So you're suffering from major depressive disorder now, but you won't always be this way. It will go away. And so it's an Axis 1 disorder versus other things that we think will stay with you. We'll put those on Axis 2. There's some validity to that, but not. There's some challenges to it too. Several disorders that we traditionally thought of as state disorders seem fairly trait-like. Depression being one of them for some people. Depressive episodes often come and go, but a tendency to experience depressed mood seems to be an aspect of some people's personality. Same with generalized anxiety disorder. When we get to that, we'll talk more about it. That some people seem to be kind of predisposed to worry, and it seems almost like this aspect of their personality, and not something that will necessarily go away after a little while. And then, so it's primarily those clinical disorders other than personality and MR. But you can also have these other conditions that are focus of clinical attention, which basically Axis 1 is supposed to be, this is the most important thing, that's why it's 1, that's why it's first. So you can put, if somebody has psychosocial problems that are a primary focus of treatment, you can put that on Axis 1. So if somebody just lost their job and you're trying to help them find another job, that might go on Axis 1. Typically it doesn't, because typically that's not a focus. That's kind of a social work thing. So we shove that down to Axis 4, which we'll get to in a bit. So you almost always, it's just disorders, but there is flexibility to put other conditions, other stuff that's going on, if it's a focus of clinical attention. Even we'll talk about Axis 3 in a little bit, medical disorders. If that's a primary focus, then it can be bumped up to Axis 1 as well. The other thing to note about Axis 1 in all 4 of the first 4 axes, you can be diagnosed with more than one thing. You don't have to pick one, right? And if you have more than one disorder, then you have comorbidity. Remember, if you're diagnosed with more than one diagnosis. And it's often helpful to specify, if you have more than one Axis 1 disorder, which one is the primary diagnosis, which can be a bit arbitrary, right? You want to consider why the person is presenting for treatment and what the focus of treatment should be. And hopefully those are the same thing. If they are, it's easy to figure out what the primary diagnosis is. Sometimes not. Sometimes somebody will come in saying, complaining about their substance abuse problem, but then you determine via your assessment that really, well, your major depressive disorder or your anxiety disorder need to be treated, and that's what we need to work on first. Once we deal with that, we can deal with your substance problem, because that's an outgrowth of these other problems. Then it's not as clear which one's primary. You don't have to indicate a primary diagnosis, but if you have one, it's helpful to indicate that. Okay, Axis 2. So these are the other clinical disorders, so personality disorders and mental retardation. Again, these were originally thought to be trait disorders, so kind of always be that way, which for mental retardation, that does seem to be the case. Few people meet criteria for it and then go on to not meet criteria. It's possible if you have mild mental retardation, but generally it tends to be a stable disorder, and same with the personality disorders, which is actually a problem in terms of the treatment of personality disorders. They're resistant to change, and they seem fairly stable across the lifespan. But that's all that would go on Axis 2 is a personality disorder or mental retardation. If they don't have either one of those, then it's no diagnosis, right? Then Axis 3, your general medical conditions, and it's not all medical conditions. It's not, oh yeah, I've got acne, and that doesn't go on there unless it's relevant to the cause, course, or treatment of something on Axis 1 or Axis 2, right? So if somebody has body dysmorphic disorder, right? And they think that their skin looks grotesque and everyone is staring at them, and they have acne, and that's contributing to their body dysmorphic disorder, then yeah, you might put acne on axis 3. Or if they have major depressive disorder, and they also have thyroid problems, well, those thyroid problems are going to contribute to and be exacerbated by and exacerbate their depression problems potentially, are important to know for the treatment for both the therapist and also other members of any kind of team. If you have other medical professionals on a team treating somebody, it's important to know that, so it goes there. If you're unsure whether or not an axis 3 diagnosis, if a medical condition goes there or not, I always say better to put it than not put it. Okay. And then axis 4, you have your psychosocial environmental problems. And again, these are things, not every problem that they're experiencing, but the ones that are most relevant to their axis 1 or axis 2 diagnoses. And you can look in the DSM and see examples of categories of problems for axis 4. It lists some of them, like educational problems, housing problems, economic problems. And you can list the category if you want, but you should always also list the specific problems. So if it's economic problems, you could put economic problems dash job loss. Or you could just put job loss, but at least always put that the specific problem, but again, at an appropriate level of specificity. So you don't have to put economic problems, got fired from McDonald's because showed up late for work twice. So job loss is specific enough. Okay. The last axis, axis 5, your GAF score, Global Assessment of Functioning. As it indicates, it's an assessment of how well the person is doing at some point in time. And often you'll give 2 scores. Their current GAF score, when you're making some diagnostic decision, and then their initial or at intake, or maybe 6 months ago, depending on what setting you're in. But it's a score, this GAF score, ranges from 0 to 100, and there's a chart at the front of the DSM that shows what the numbers mean. But basically, 0 to 100 is for symptom severity and level of dysfunction, and it's broken down into deciles. 0 to 10, 11 to 20. So on and so forth. And each decile, each group of 10, has a description of symptom severity and dysfunction. And you have to pick the lowest score that's true for either severity or dysfunction. Right? So if you read the description, you say, well, the symptom severity is in the 31 to 40 range, but their dysfunction is down in the 21 to 30 range, then their GAF score is the lower of the two. It's somewhere in that 21 to 30 range. And then there's not much advice beyond the decile how to pick, well, where between 21 and 30 are they? It's up to your clinical judgment to think, okay, are they at the higher end or the lower end? And then you pick some number. And because there's not much guidance and you pick some number, there is debate about the utility of GAF scores and the validity of that particular number. One other thing about the multi-axial diagnosis, for axes 1 through 3, there are numerical codes that you provide in addition to the textual description, and you always list those, and that's helpful for a variety of record-keeping reasons. An example of what it might look like if someone with here has 2 axis 1 disorders, so 296.23, and usually the decimals differentiate between different specifiers or subtypes. So 296 will be major depressive disorder, and then what type of major depressive disorder the next 2 decimals will tell you about. And this particular person had a single episode, so they've had 1 major depressive episode so far in their life. If they have another one, their diagnosis will change to multiple episodes. And that episode was severe without psychotic features. Okay. They also met criteria for alcohol abuse. And then on axis 2, met criteria for dependent personality disorder. You notice on 3, there's no diagnosis. And it's kind of which is one of the weird things about the DSM. On axis 3, when there's no diagnosis, you just put none. On axis 1 or 2, if you put no diagnosis, you put no diagnosis instead of the word none. And there's also a code for no diagnosis. I guess bookkeeping stuff. Then at axis 4 there, you see threat of job loss. And axis 5, they have 1 GAF score down at a 35, which you notice it's a 35 right in the middle of a decile. And that's often what people do, is they figure, okay, where they're at in the decile, and it's just right about there. It's not in between one and the other. It's right in the middle. So typically you do that. So it's right in the middle, or it's a 39 or a 31. You don't see many 33s, 34s, 36s. Just kind of by experience. One other thing to note about this example, there's not a primary diagnosis indicated yet. It might be that they're focusing on both of these axis 1 disorders and treatment, or it might be they just haven't, when you made this diagnostic decision, you hadn't decided yet what the primary diagnosis was. Okay. Okay, now's probably a good time to take a little break if you'd like. You don't have to, but you could pause it here, and then we're probably about halfway through the lecture. Okay, now let's talk a little bit about some of the information you'll find in the DSM about disorders, because it's not just diagnostic criteria in there. Obviously, it's a big book. So other stuff you'll see. Diagnostic features sections for each disorder, which include a narrative description of the symptoms that are used to diagnose disorder. Associated features, which often has a couple of components, but it's typically a narrative description of difficulties that are common among people who meet criteria for a particular disorder. So these are experiences that are associated with a disorder, but not necessarily diagnostic. You don't have to have them to be diagnosed. There also is included for some things associated lab features. So if there are any consistent biological findings related to the disorder or to its treatment, people with disorder often have low protein, or late stages of anorexia associated with kidney failure. That type of stuff will be in there. Culture, age, and gender features, usually information about how the disorder may present or look different in different groups of people, and then some epidemiological information about group differences. Related to that, a prevalence section, which is general epidemiological data. Usually presents both in the community and then in clinical settings. So in the community, this occurs in 1% of the population, and then other people presenting to treatment, it accounts for 10% of that population, whatever it may be. A section on the course, which talks about things like the typical age of onset, whether the onset is abrupt or insidious, so it develops slowly over time. If the course is continuous or discrete, if it's fluctuating, if it's a deteriorating course, all that type of stuff will be there. Familial pattern, which talks about whether or not the disorder is often seen in family members, which is often cited as evidence of genetic influence, which is debatable. We'll talk about that. And then the differential diagnosis section, which is, I think, for me, one of the most helpful sections to read, because it talks about, okay, to be diagnosed with this, it sometimes may look like this, but the way you can tell them apart is if this is present, right? So it tells you for all things that might kind of look like that disorder, but and kind of identifies what's the distinguishing factor when making your decision among or between those disorders. So, mood disorder with psychotic features versus schizoaffective disorder. It'll tell you how it's the difference between those two disorders, because both of them involve some hallucinations, delusions type things, and significant mood symptoms. But they're two separate disorders and are diagnosed differently. And then, obviously, the diagnostic criteria, which we said before, are often polythetic. So typically, 5 of the following 9 are true, right? And it breaks it down into usually A, B, C, D, with the kind of defining characteristics of the disorder being the first symptoms, and then working their way down to the clinical significant stuff, and then rule outs. So you can't meet criteria for some other disorder and still get this label, that kind of thing. And then one more section you may see, specifiers or subtypes. Different disorders may specify a type of course, where somebody's at in the recovery process, partial recovery, full recovery. They may have a specifier for key symptoms, schizophrenia with catatonic features, with melancholic features, whatever, or severity, mild, moderate, severe, that type of thing. Okay, so lots and lots of information about psychopathology in the DSM itself, beyond just diagnostic criteria. So really, an interesting read. So, some issues and controversies about our current approach to classification and diagnosis. One, there's a concern about whether or not we're classifying individuals or disorders. And the DSM specifically says that we're not classifying individuals, we are classifying disorders. But then it's a bit of semantics, because when you get down to it, when you diagnose people, you're not diagnosing disorders, you're diagnosing people with disorders, right? But one of the reasons it's a concern is because of the potential stigmatizing effects of being labeled with a mental disorder, right? And it depends. Some labels are more stigmatizing than others. By that, I mean they're associated with kind of a negative impression. If people learn that label applies to you, it may change the way they feel about you, the way they treat you, and also the way that you feel about yourself. And because of that, there's a big push and an emphasis in American Psychological Association, APA, and in other areas as well, for person-first language for mental disorders and for any kind of illness or disability, that not to define people by some condition that they're experiencing, right? So you're not somebody who is a schizophrenic. You're a person with schizophrenia, because there's a recognition there that there's a difference in experiencing that, right? You may say, oh, that's just words. But no, if somebody says you're a schizophrenic, then that set of experiences defines you. If you're someone with schizophrenia, it's part of the definition of you, but it doesn't define you as a person, right? And we don't do that with other things. We don't say, oh, you're a cancer, or you're somebody with cancer, right? So in this course, and I'd like for you to try your best to use person-first language, even though our own textbook doesn't always do that. We'll attempt to talk about somebody that suffers from or is diagnosed with, would be the most appropriate way to say it, diagnosed with major depressive disorder, diagnosed with delusional disorder. Right? Okay. Another issue is related to the supposed atheoretical approach of the DSM. So the idea being that, getting away from originally we talked about before, that they were very theory-driven. It was based on kind of ideological theories. And the DSM was meant to be just a manual that describes, it's a descriptive manual, but not a theoretical manual. So it describes these disorders, but doesn't give... not guided by or bound by theory of ideology or otherwise. And there's several reasons for that. One, it's made for diverse users, right, who differ in their opinions about psychopathology. They have different theories. And so you increase the acceptability of the manual and its utility and how likely it is to be used by trying to make it atheoretical. And also we figured out that at least making it theoretical based on an ideology is untenable, because even though we haven't figured out the etiology of all disorders, what we have figured out is all disorders are multiply determined, right? It's no longer a is it nature or is it nurture debate. It's a how, in what way do nature and nurture interact, right? And when we talk about nature, we're talking about lots of different things. We're talking about nurture, we're talking about a lot of different things. So in what ways do these variables interact? And so it would be unrealistic to divide up, say, okay, well, these are disorders that are caused by faulty genes, or these are disorders caused by too much serotonin, or these are disorders caused by your mother not breastfeeding you. We figured out that doesn't work. That etiology doesn't work that way. It's not that simple. So we can't use an etiological theoretical approach. Another kind of debate related to this atheoretical approach is, well, is it really atheoretical? It's certainly not clearly an etiological theory, but closer examination of the DSM reveals several kind of assumptions about psychopathology, which would seem to provide a basis for theories. There's kind of implicit theories behind the scenes, and one of the most controversial implicit assumptions back there is this kind of influence of the medical model, right? So we call these things disorders instead of diseases now, but we still write about them in the DSM as if they were diseases and talk about symptoms. And the word symptom itself is part of the disease model. And a disease implies an obligation for cure and the possibility of cure. And there's a possibility that some of these aspects of psychopathology, some of these mental disorders, are experiences that are differences and not diseases, right? Or that they're simply difficult experiences, but that the disease concept doesn't really make as much sense as it does with tuberculosis or cancer or any other kind of thing we think of in the medical world. Nonetheless, there does seem to be this kind of medical model in the background that's always ever present and still there in the DSM. Excuse me. Another issue, concern, which we've already talked about a little bit, reliability. We talked about it with the early versions of the DSM, and still there are some problems with reliability. And there are multiple types of reliability we could talk about from test theory, but for diagnostic categories, the most relevant type of reliability is inter-rater reliability. Right? So to what degree do people arrive at the same diagnostic decisions when given the same information? So it's inter-rater reliability. And some disorders have pretty good reliability. We do a pretty good job of taking this set of rules and say, okay, yeah, we all agree that this person has PTSD. Right? Other disorders have lower reliability, especially some of the personality disorders. People have a hard time agreeing on which personality disorder it is, or sometimes distinguishing between something like social phobia, generalized type, and avoidant personality disorder. An axis 1 and axis 2 disorder, two different axes, but they look a lot alike in the real world, and so there's not good inter-rater reliability between those two when rating those making diagnostic decisions for those categories. So some diagnostic categories seem to be just kind of crappy and problematic in and of themselves. So the criteria aren't specific enough, or there's too much overlap with other diagnostic categories, and that's problematic. But another problem is when we see these kind of systematic problems where the differences in reliability indicate or possibly indicate a bias in the application of the diagnostic rules. So maybe the rules are okay, but they're not being applied equally with all individuals. For example, if you give a case report and you don't put the gender on it, and you describe someone with features of histrionic personality disorder, and then you print out a bunch of those, and half of them indicate it's a man, half indicate it's a woman, you'll get the accurate diagnosis more often if you say it's a woman than if you say it's a man. If you say it's a man, they may diagnose something else, probably narcissistic personality disorder, right? Even though it's the same information, all you change is gender, and gender isn't part of the criteria, but we get these differences in diagnosis. And it's gender, ethnicity, age, and SES are all variables that seem to influence the reliability of some categories, possibly indicating bias in the use and application of the diagnostic rules. So, again, doesn't mean there's problems with the rules, or is that problems with our use? Maybe both. Okay, related to that, something I already touched on, this idea of diagnostic overlap, right? So many disorders have diagnostic criteria in common, right? So, for example, sleep disturbances and irritability can contribute to a diagnosis of generalized anxiety disorder or those same diagnostic features can contribute to a diagnosis of major depressive disorder. Right? That can be a problem for a variety of reasons. One of the biggest reasons is it may contribute to artificial comorbidity, right? And comorbidity is just being diagnosed with more than one disorder, which there are high rates of comorbidity among mental disorders. Once you're diagnosed with one, it's pretty likely to be diagnosed with another, especially among the Axis II disorders. So it's especially problematic when the comorbidity is artificial. And by artificial, I mean the person doesn't really have two disorders. They don't have two kind of key problems in their lives. They have one problem, and it kind of overlaps with features of another, which leads to a secondary diagnosis. But to understand them, if you only knew that one diagnostic decision, you would understand them just as well. And adding the other label either doesn't add anything or adds error, adds confusion, and kind of distracts you from what's really going on with the person. And concerns about high levels of artificial comorbidity are most often associated with personality disorders, which isn't surprising given the amount of symptom overlap that occurs across those disorders. So that can be a problem. Another possibility here is that the overlap is accurate, and it's an indication that the disorders aren't as discrete as our neat little taxonomy would suggest. Right? There are very high levels of comorbidity between depression and anxiety disorders. And some of this is associated with diagnostic overlap, but it's possible that these are not discrete categories, that depression and anxiety are simply variants in the manifestation of the same emotional difficulty. So maybe there should be some Uber diagnosis that's like negative affective experience. Instead of dividing these things, maybe we're artificially dividing them, at least for some people. That's an ongoing debate about what these levels of comorbidity mean, and if they're being, if we could parse out some of these issues with comorbidity by having tighter diagnostic categories with less overlap. To where, okay, if you have this symptom, it can only count toward this disorder, and it cannot count toward this other one. Okay. A related issue is this idea of maybe we're not even thinking about these things the right way. We're thinking of them as categories, but maybe we should be thinking about psychopathology from a dimensional model, right? So it's possible that some aspects of psychopathology can be better understood and more effectively described as continuous phenomena. So instead of, are you depressed? Yes or no, which is kind of what we have now. But instead of that, how depressed are you? How much negative affect are you experiencing? And having it on some continuum rather than artificially cutting the continuum somewhere and saying, okay, yeah, you meet criteria. No, you don't. And taxometric studies that use really very complicated advanced statistics kind of look at these things to try to figure out if disorders form taxons, if they form discrete categories or not. Indicate that some disorders do appear to be fairly to be discrete categories, but other disorders not so much. So they're not equally categorical in nature, which if we had some categorical and some continuous, it's going to make a very messy taxonomy. But that might be better reflective of the way things really are. So that's something that we may see in the next version of the DSM, the DSM-5. Is one thing they're talking about is having some aspects of psychopathology being represented via kind of dimensional means. Okay. Another important issue, probably the important issue, would be the validity of the categories, because validity is all about truth. Are these things really what we say they are? So do the categories really reflect mental disorders that we say? And so it's part of, does it reflect a mental disorder? And also validity is related to utility. So are these descriptions useful for the purposes we talked about earlier, right? We talked about why do we classify. So given our current classification system, are we meeting those needs? Are we able to communicate better? And is it helping researchers? And are we clearly talking about the same things when we're using these labels? Excuse me. Now, one of the challenges to validity would be partly because of the polythetic criteria sets, and partly because of the nature of psychopathology itself, is that we have these very heterogeneous groups, right? So when you say someone has major depressive disorder, you're communicating some information about them, right? So, okay, major depressive disorder, single episode, moderate. Okay, so I know this person, and that's all they have in Axis 1. I know they're not having hallucinations. I know they're not having delusions. And I can make kind of several other assumptions about what's not going on with them, and some assumptions about what's generally going on with them. But there's still some information I don't know, because to get that label, you can still have a lot of stuff going on. I don't even know if their primary mood symptom is depressed mood, or it may be anhedonia, right? Loss of interest or pleasure in most activities. Because you can have either one of those and be diagnosed with depression, right? So you don't have to, your primary mood symptom does not have to be depressed mood to get diagnosed with major depressive disorder. So two different experiences, same label. So if there's different kinds of people in that group that I'm calling major depressive disorder, how much useful information am I communicating? Certainly some, but maybe not as much as I could be. Well, is the answer then to further subdivide all the disorders into all the different parts? Well, we've already got a crap load of disorders. If we further subdivide, okay, it's this type of depression, or this type of depression, or this type of depression, we're just going to exponentially start increasing disorders. And if we do that, we're probably going to also lose some of the functionality and utility of our taxonomic system. So there's some challenges to it, there's some problems with it, but unfortunately nobody has a good answer of how to fix it yet. Okay. Another challenge to the validity of some of the disorders is that the criteria for symptom cutoffs. Remember, we talked about you have to have X number of symptoms, and usually it's like 5 of 9 or 4 of these 7. But how many symptoms you have to get diagnosed were determined somewhat arbitrarily, right? These were decisions made by committee. So in the end, I mean, they did research and they looked at statistics, but in the end, it was a raise of hands. How many of you think 5 sounds good? How many think 6 sounds good? And so when you do that and use that process, it's going to introduce some error into your system, and that error will undermine some of the validity of your taxonomy. Excuse me. And the last thing I've already alluded to is that, like I said, the DSM is put together by people, and people have biases, people have agendas, and the results of work by any committee, no matter how well-meaning they are, will be influenced by cultural and political variables. One of the chief criticisms of the DSM along these lines, and of arguably psychiatry in general, has been that it's biased or unrepresentative, at least, of the experiences of women and ethnic minorities, because the decisions being made were primarily, not in totality, but primarily made by upper middle class white men. And so is this this view of psychopathology, is it so culturally bound that it doesn't accurately represent all individuals? And if you read some of the criticisms, there's several good points out there about that. But again, it's kind of like, well, what's the alternative? Try to come up with different systems for different types of people, and then what type? Do you have a male system and a female system, and does that make sense? Because the research on gender differences suggests that men and women are more alike than they are different. It's several cans of worms to open and think about. But it is important to realize that what we have with the DSM is not just the result of science and experience. It's also the result of cultural and political agendas and compromises. Okay, summing up, things that you should know, or I want you to know, after reading and listening to this and doing some other thinking and reading, hopefully, I want you to know why classification and diagnosis is necessary, why we need to have some rules, and what it's good for, right? I want you to know why the decisions about classification are important, why you should care how the DSM-5 is being put together, right? That it's not just, okay, well, I'm sure that I can trust them to do the right thing and it won't really affect me or anybody I know. It will. And I want you to know why you need to care about those decisions and who's making them. Okay. I want you to know how is psychopathology currently being classified and diagnosed, and it will change some in the next couple of years when DSM-5 comes out. But like most things, probably not a radical change. So be familiar with how we're doing it now, and then also I want you to know what are the limitations of the current approach. What are the kind of the criticisms, and then think about, well, what are the answers to the criticisms, and then, well, what are some potential solutions to those problems, right? So these are all things I want you to know. And overall, I want you to have, a healthy skepticism of the DSM. And when I say healthy skepticism, I don't want you to go and think, well, this is all just garbage. It's all just a bunch of stuff people made up, because it's not. There is a lot of clinical experience and science to support much of what's in the DSM. Right? But I don't want you to go and think, well, this is all gold. It's all perfect, and it's all done without bias, and it's super accurate. Because that's not true either. Right? I want you to recognize that it's what we have to work with now. I want you to think about how it can be useful to you and your clients. Also think about how it could be harmful to you or your clients. And then think about how it could be improved. Because you probably won't have much chance now for input on the DSM-5 because they're getting close to being done. But whenever you are a professional and have your license, they're going to send out surveys, and they will post on the web asking for people's opinions, and you can share your opinion. And I'd like for your opinion to be one that's educated and thoughtful. So think about it, because DSM-5 won't be the last version. They're going to revise it again, and you could play a role in shaping what the next version, what the DSM-6 might look like. So be ready for that. Okay, that's all for now. Take care.